Have any. We can move into the second order of business, which is questions for the Department of Corrections regarding the suggested rule changes for the proximity requirements in advanced practice registered nurse collaborative practice agreements, as the numbers indicate. I assume that everybody has read through the questions and the responses to those questions. Is that, I see the head shaking from everybody. Does anybody wish to discuss the responses? Go ahead, Dr. Matthews.
So if I recall correctly, we were being asked to waive the mileage restriction.
Correct, waiving the 75-mile restriction.
And so with some help, I've gone back into the statute, and regardless of what we think of the statute, that's a legislative issue. And the statute is really clear. It's section 5B, that there's only one situation where that what's called geographic proximity requirement can be waived, and it doesn't apply to this situation.
I think that's a legal opinion, and I think that's your opinion, and I would to.
I'm having trouble hearing you, and
I'm having a hard time hearing you, Mark.
I said, I think that's a legal opinion. Can you hear that?
Yes, and I've consulted with our legal on this.
I think that's your opinion as an individual board member,
Mhm.
but I think that should be resolved by our legal counsel.
Dr. Carter?
Yes, I was going to ask, is what Dr. Matthews just stated, is that statute or is that in the rules?
Bailey, do you want to speak up?
Yeah, so the language that she is talking about is in statute. It's section 334.104 of and that is what governs the collaborative practice agreements between physicians and providers.
There is a later section of the statute which defines the scope of rulemaking. And again, our legal experts can chime in, but my understanding is it doesn't override or create another exemption around other grounds for waiver of geographic proximity.
What does it specifically say?
It says, maintain geographic proximity, except the collaborative practice arrangement may allow for geographic proximity to be waived for a maximum of 28 days per calendar year for rural health clinics as defined by PL 95-210, as long as the collaborative practice arrangement includes alternative plans as required in paragraph C of this subdivision. This exception to geographic proximity shall apply only to independent rural health clinics, provider-based rural health clinics where the provider is a critical access hospital as provided in 42 USC section 1395 I-4, and provider-based rural health clinics where the main location of the hospital sponsor is greater than 50 miles from the clinic. The collaborating physician is required to maintain documentation related to this requirement and to present it to the State Board of Registration for the Healing Arts when requested. So that's the section which could, again, and legal can speak to this, and we've been back and forth, but that defines this part of the statute and that there's only one situation where this can be waived.
Dr. Taormina, what do you think? What are your comments on that?
My comments would be that I think as a board, if we feel, is everybody able to hear me okay?
Yes.
Yes.
I think as a board, if we feel that this is in the best interest of Missourians, whether they be incarcerated or not, that we look at it at the purpose of the request, and what the interest would be, and we would vote, and we would let the the results of the vote kind of speak for themselves. And if anybody would challenge that, then I think it would be up to the board or our legal advice to explain why we voted in the way we did. But I think that to just not address the issue because of a question about the statute is not appropriate. And as a board member, I think the question should come to the board for a vote, and then let it fall where it may.
Any other comments?
I know Dr. Taramina and I are giving us grounds for thought. I come to this with a specific set of observations about the process of governance, particularly during the pandemic. We've spent a lot of time as a society, as a state, and here in the St. Louis region, thinking about which branches of government have which authority. It's really been clear that in our state, when non-elected bodies move into a zone that is more appropriately decided upon by elected bodies, that has generated a lot of lawsuit backlash. And so I think even if we hadn't just been through the pandemic, I would be concerned about what authority we actually have as people who are appointed and not elected. And that's why I've gone back to the statute itself.
Jorgen, would you like to say something?
I would, thank you. I wasn't clear on the format of whether the general public could speak at this point or if this is solely a discussion among the board members at this point. But if you're recognizing me, I would like to say a couple of things. And I've got a couple folks on the phone from Centurion. So Dr. Matthews, I just looked at the statute and I think your points are very valid. And however, I don't think that the statute, maybe our request should be amended. Instead of waiving it, we would like you to expand the mileage amount that you are allowing for Centurion, who is the operator of the healthcare for the Department of Corrections. And instead of simply waiving it, which there could be some friction between that and the statute, simply expanding the mileage to several hundred miles, that is well within the scope of the statute and allowed by the statute, it would still resolve, I think, our issue. I would certainly ask Kent maybe to weigh in on that or talk about what a mileage requirement might be that would satisfy us being able to deliver healthcare on a timely basis to these prisoners. And at the same time, giving you a number that you could adopt and still remain within the statute confine.
And Jorgen, do you work for Centurion?
I'm a lobbyist here in Jefferson City, and they are one of my clients. Yes, ma'am. Kent, are you on?
Go ahead. We can't hear you.
Is that better?
Yes.
Thank you. I appreciate, Jorgen, where we are at this point is problem solving. And we're open to whatever solution maximizes our capacity to deliver care. And so that's the root of our request is I think you've seen our comments and responses to the questions. We're simply in a dilemma here. There are remote locations in the state where there's been historic challenges in recruiting physician collaborators, where we're also experiencing great difficulty in bringing on board site collaborators, and which is then sometimes double and triple the challenge when we're crippled with our nurse practitioners not being able to deliver care as well, creating tremendous backlogs, tremendous expense to the Department of Corrections to transport our patients to community providers, So it's creating an extreme burden on the Department of Correction and greatly hampering our capacity to deliver care. So we would appreciate any consideration and how we solve this this challenge. That makes the most sense to this board to allow us to have a greater flexibility in addressing this.
And
Thank
who
you.
are you, by the way? What is your role?
My name is Kent Runyon. I am an employee of Centurion, and I'm the Vice President of Operations. So I'm the lead person over the Centurion contract with Missouri.
Were you one of the persons that answered the questions that came to us? Because we don't know who these came from at all.
Yes. It was myself in consultation with our statewide medical director, Dr. Jerry Lovelace.
Is he on the call with us tonight?
He's attempting, I've been texting with him. He's telling me he's waiting to be allowed in by the host.
Dr. James?
Good evening, everybody, and thank you for joining us. What I heard from the two gentlemen is that this is a staffing issue, but what I'm familiar with, and part of what I heard, is that physician staffing is a historic issue. So this is not just related to COVID-19 and the shortage, that this shortage has been there for some time. So my question is, what other strategies have been employed for providing healthcare services such that we get to the collaborative practice agreement being the hindrance to providing adequate or equitable care when this has been a long-standing problem? So what other things have been employed to try to solve the issue as well?
Jimmy?
Mr. Runyon, you are muted again, but also could you let Dr. Lovelace know that he's clicked on the meeting for next week?
I will.
Thank you.
And to answer your question, we've had this contract since November. So we have a short history to address your point. So we are, as far as recruiting goes, we are actively working on different strategies to improve our success with recruiting providers and physicians around the state. We do have a good number of physicians who are willing to be collaborating physicians. What we're encountering is they are outside the mileage restriction, which is and this is impacting us both on the medical side as well as the psychiatric side. We have psychiatric nurse practitioners who are also being impacted by this. So recruiting the psychiatrists and physicians around the state has been a factor. But to your point, we're as we learn more about the state, we're expanding our strategies on how we recruit in these other more distant regions, in these more rural regions, to have more success. The challenge for us is even if we're more successful, if we have a physician resign or go out on sick leave unexpectedly, even on our best case scenarios, we may be without a capacity to deliver care in the way we would like to for quite some time. 1 to 3 months. Typically, from starting from scratch to hire someone, you're typically going to be 2 to 3 months on our best case scenarios. In these more remote situations, it's much longer than that. So that's our concern, is that even as we have more success, and regardless of what we do on the recruiting side, this is going to be a long-term challenge, I think, for us in delivering care.
I'll let you answer, but my second question and follow up to that is, where does the use of telemedicine, where and how does the use of telemedicine come into play in terms of your care delivery?
Yeah, that's a great question. We do have telemedicine across the state, and we're actively using telemedicine as a part of our strategy for delivery of care.
Dr. Carter, you had a question, I believe?
Yes, thank you, Dr. Glazer. I was going to ask for more of a picture of what medical care in the context of this shortage looks like. How is it being impacted in terms of the ability for the patients or the people being treated to get care that they need? What's happening if we're hearing that there is no collaborator? What are you doing to meet the healthcare needs of those involved?
Well, two things are happening. One is that the nurse practitioners are having to, during this span of time, act as RNs. So, obviously they can't deliver the same level of care. And we use telemedicine is a strategy, but we cannot fully meet the needs of these patient loads solely with telemedicine. So that's greatly hampering our delivery of care. So what's resulting is tremendous backlogs. It's putting pressure on the Department of Correction to transport patients that we normally could have provided care for within the confines of the institution and transport them into the community. And as we know, the Department of Correction has significant staff shortages as well, which is placing a lot of pressure on them. And so it's simply impacting delivery of care. Not everyone's getting the level of care that they should be receiving.
Dr. Taormina?
I had a question. I asked several of the questions that you answered, but one question that I did not ask, which comes up because it's in the rules and regulations, is a 30-day requirement that the APRN practice alongside the collaborative physician. It sounds like with your staffing issues and everything that's going on, how is that being done, or is that an issue in terms of following the rules and regulations is currently written?
And I'm happy to answer that, although I think maybe Dr. Lovelace may have joined us. Let me confirm if he's on or not. This would be his expertise. I don't see him, so I'll answer for you. We asked the nurse practitioner to train alongside their collaborating physician at the site where that collaborating physician is located. So they will drive and we'll address the distance with them to train alongside them at their host institution. Or in some cases, the site physician will go to their site and work with them there as well.
Mr. Runyon, Dr. Lovelace did make it in the meeting.
Oh, great.
Did he have any comments on that?
And you're on mute, Dr. Lovelace.
I just heard the tail end. What was the question?
How do we provide the 30 days of direct supervision with nurse practitioners by the collaborating physician, given some of the challenges with distance?
Yeah, they generally go to the site where the collaborating physician is located for the 30 days.
Okay,
Dr.
thank you.
Matthews?
I had, partly this is me wanting to get a clearer picture, and thank you for being creative with problem solving. As you know, a mileage change is a joint decision with Board of Nursing. And so would ask, I know you threw out a mile number, but that if that was off the top of your head, that you really look at a mileage recommendation. Part of our concern is also considering that standards for people who are incarcerated would be the same standards for people who are not. So just wanting to think through those details. my questions goes to some of the financial piece of this. So if people who are incarcerated have to get care in the community, is that then you're having to pay for that out of your budget? And I'm also curious about the compensation structure for the collaborative practice physicians. How do you have that structured? Is it a percentage of their time? Are there incentives around their compensation? Just trying to get a bit of a picture about that for my own background.
Dr. Lovelace, do you want to talk about the utilization management piece?
Yes. So when we send people off-site, we do handle all of the off-site fees, sort of like an insurance company does. So, and that includes all our subspecialties, all of our inpatient stays as well. In terms of compensation for the physicians, it's sort of a part of their expectation, and there's no separate structure for their salary for that.
And when you hire physicians, are they working for you full time, or are these people who have other day jobs and they're doing this as a side gig? And again, regardless, do they have a set salary? Do you have an incentive program? The more care you keep in-house, the more money you make. I'm just trying to get a really transparent picture here.
Yeah, most of our physicians are full-time. We have maybe two that are 75% of the time. There is no compensation where if you send people off less, you get paid more. It's just a straight salary.
And I'll add that we have a staffing matrix as part of our agreement with the Department of Corrections. So there's no disincentive to fill vacancies. To the contrary, we highly desire to have every site physician, every site medical director position filled. That's in our best interest to have these positions all filled across the state.
And I think that actually connects to the final question that I have. There's also within the statute a limit of the number of collaborative practice relationships, and so I see nodding heads. So your intention is staffing up so that you're well within that limit.
Correct. Yeah.
Yeah, absolutely. And I'll just add, and Dr. Lovelace, I was actually on a conversation this morning, and again, we've only been in the contract since November, but we are looking at the possibility of having some compensation for being a collaborating physician. Again, the challenges we've had with recruiting, we're looking at a variety of new strategies to do anything we can to make this position, make our physician. Yeah, as you can imagine, recruiting for work within our prison system is a challenge to begin with. So we're evaluating a variety of strategies around compensation within the scope of our budget that we have with the Department of Corrections to make these positions as attractive as possible.
How big of a problem is this? What percentage of the care that you deliver you would say that this affects? How big is this problem?
Well, I can throw it out this way. We have 21 institutions where we're delivering care. And I think, Dr. Lovelace, I think we would say that, I know on the mental health side, we have two sites where our psychiatric nurse practitioners are being impacted. And I believe on the medical side, we have another 1, 2, 3, 4, maybe 6. So that's 8 of the 21 that have either recently had challenges or are currently experiencing challenges as a result of this mileage restriction. If that gives you any scope.
Sorry.
Dr. James.
So, Centurion, I know that you are relatively new to Missouri. Are you guys relatively new to the corrections market? Because some of the questions that I'm asking, I guess, is based on kind of what your experience is, even if that experience is not in Missouri. And so I'm going to ask a similar question to one that I asked earlier, in terms of have your strategies ever included collaborations with other organizations to help with the sort of delivery of care / law enforcement issue? I know that, you know, prisoners have to be transported, but there are situations, I'm not going to say oftentimes, there are situations where there are collaborations amongst organizations to try to alleviate the burden sort of on both sides. So again, I'm just trying to get to the understanding of why the collaborative practice in Missouri seems to be the fix to a problem that has been quite longstanding.
Jorgen, you want to go ahead?
Yeah, this is Jorgen Schlemeyer. So the one thing that I wanted to note, and I probably should have said at the very beginning, is Centurion began their contract in October or November. I can't remember. It was this fall. And so they came in at a time when it was the height of difficulty of recruiting. And so while they're working through these challenges, they have had very challenging times starting. It'd be different if we had already had the contract for 6 years, right? And we've kind of got a little bump in the road, but trying to come into the state startup and recruit during these difficult challenges is what's necessitated the leniency that we're asking you all for.
And I'll add, you spoke to the Centurion's experience in the field. We're not new to the field of healthcare in a correctional setting. The name Centurion is a few years old, but before that it was MHM, which actually had a presence even here in Missouri many years ago. So Centurion / MHM has been in this field for a good number of years around the country delivering care. Dr. Lovelace, would you like to speak to the question as far as the possibility of having other collaborating relationships with associations in the communities where we're having these challenges?
So first, I wanted more clarification on what kinds of collaborations that you were referring to.
I'm going to chime in with this, and just for you to know, both Dr. James Halbert and I have spent our entire careers serving populations that we would define as underserved, and Dr. James Halbert is actually overseeing care within the jail system within St. Louis County. So we're coming at this with a real passion for providing appropriate care, and I in particular do care around behavioral health. And so the attention to mental health services is very important to me. So, you know, one possible partnership in the past, St. Louis County for their jail contracted with St. Louis University. Another example around mental health would be the community mental health centers. And I hear you saying that you're having trouble with psych, but we all have trouble getting access to psych. So I think from a quality of care for people who have probably suffered a lot of trauma in their life, may have co-occurring mental health and substance use disorders. Really, I know this is a little outside of the decision today, but out of our concern for these people as part of the state of Missouri, really encouraging you to think creatively about how you might meet those needs appropriately. Federally qualified community health centers could be other partners.
The challenge for us there is that they also would have to be credentialed by the Department of Corrections in order to come into the facilities. So we couldn't make standalone contracts without that partner's buy-in.
We all live in the world of credentialing. And so I just would encourage you to think through that. I don't think, as you're looking at multiple ways to solve this problem, I don't think a separate level of credentialing is really a deal breaker.
Sure.
And certainly I welcome and I appreciate that input, and we're open to looking at all possible solutions. And 18 years of my career was working in the nonprofit sector, so I'm certainly accustomed to partnering with community providers and local and having those kind of local relationships. And you know, I can't speak to those relationships that you spoke to and what their capacity would be in some of these more remote areas that we're struggling in, because that's where, in particular, we're having the greatest challenges is in the most remote areas of the state.
As a board member who is not really practicing in those areas, I'd like to reiterate that I think I can speak for every board member here that we're all interested in the health of Missourians, whether they be free or incarcerated. And it's not just limited to people that work in federally healthcare, you know, qualified centers. For me, in private practice or wherever, you know, we all have the same goals and our goal for quality of care. And so I think that I want you to take away from this meeting that the goals of every board member here is to care of all Missourians. And I think access is the issue here. You cannot really give quality care unless you have access, you know, and I think we're all going to be thinking out of the box about ways to collaborate with APRNs in a more favorable fashion as we're moving forward with the new technology that we have today, because many of these rules and regulations were written, you know, before the new technology with telemedicine and that type of thing.
And I'll add, you know, one of the benefits we do have with some of the distance issues that, you know, I believe Dr. Lovelace can attest that he's able to do chart reviews and review the work of our providers from his office. So we do have some capacity. So we don't want to suggest that we want to minimize or not provide quality collaborative oversight with our providers. And we believe we do have some capacity to mitigate some of the concerns if we were given the opportunity.
With the telemedicine rules and statutes, the mileage doesn't really come into play with the use of telemedicine. So if the mileage is, if you have the capability of telemedicine and the mileage is not an issue for the use of telemedicine, how is that not enough with the current collaborative practice agreement?
Dr. Lovelace, you want to speak to how we use telemedicine versus how we do use our providers on site?
Yeah, so with the sites that we're talking about, there's a total of 7 positions that are vacant, but there are also 9 nurse practitioners. So even if we use the telemedicine folks, and we use telemedicine people at those sites now, but even if we ramp those up, those nurse practitioners that we have couldn't see patients, and so the volume wouldn't be the same.
Right. You would essentially have 2 providers per person, which would telemedicine would be good in certain instances, but you would have a nurse practitioner on one end and a physician on the other end. And so you'd be tying up 2 providers for one patient, and that gets inefficient in a hurry.
Well,
But if distance is the issue, I don't know why tele isn't a better solution for you.
Well, telemedicine, and Dr. Lovelace, you know, feel free to jump in, but the space and the capacity to have telehealth equipment is limited. So, you know, at each site we may have one telehealth unit, which we use with our telehealth providers. which is helpful and allows us to deliver some care there, but just can't keep up with the volume that of care that we need to deliver by on-site providers. Dr. Lovelace, is that?
Yeah, and with the nursing shortage that we have, we don't always have an available nurse to accompany the telemedicine doc. And so that limits the number of telemedicine visits that we can have as well.
Other questions? Go ahead,
Well,
Dr.
I guess back to what I think we can do, was that 200-mile, was that just off the top of your head? Have you looked at specific distances, which are under our purview to define the geographic proximity with the Board of Nursing? Have you mapped that out? Do you need to go back and map that out? They're not here tonight. We meet with them next week.
Yeah, Dr. Lovelace, thank you. Missed that conversation. The question was, if we can't be exempted from the 75 miles, but instead the opportunity was to expand the miles, what we think the number of miles for these sites that most commonly are struggling, what additional miles would allow them to be within proximity of a collaborating physician?
So I guess the big thing would be to get to the providers where we're staffed in the central region. So in Jeff City and Boonville now, and that 200 miles would cover that for either the west side of the state or for the east side of the state.
Dr. Matthews, we do have some representatives here from the Board of Nursing.
Oh, we do? Okay. But my understanding of that is we'd need quorum from both boards.
Correct.
Okay.
Just if you had any questions, there are a couple of folks.
I just don't want to get ahead of what we tonight might be able to do.
Yeah, I think 200 miles gets you down to Licking. It gets you over to Kansas City, to St. Louis, up to Labadie.
What about
and-
the hypotenuse of the triangle, like down into the Boot Heel? I don't know where all the corrections facilities are.
There's one there southeast, and there is a position there currently.
Okay.
Cameron, is Cameron an issue?
Cameron would be within 200 miles as well. Mhm.
Any other questions or
When we
comments?
say the mileage, the focal point is each correctional facility, and it would be within whatever the mileage is of that facility, right?
It would be where that practitioner is. So I was trying to think of the kind of the furthest facility. So Cameron, let's use that. And their collaborating physician. See, I said it just like you. Collaborating physician would be in Boonville or Jefferson City, as I understood it, and that would be within 200 miles. So you would still have to ensure that the physician and the APRN, regardless of at which facility that practitioner was located that day, was within the 200-mile range.
And Dr. Lovelace, I think we agree that 200 miles would be sufficient.
Yeah, so that would be adequate for all of the facilities except for southeast, but they're covered already.
Any other questions or comments from anybody on the call that hasn't spoken or has follow-up they wish to add? We have some legal issues that we wish to discuss and closed. What is the feeling?
Okay.
Anybody? Everybody?
I guess this is still for open. Just the other thing that I know we talked about last time that each of us may bring our own perspectives to, but thinking uniformly. So if, you know, a standard for people who are incarcerated, from my point of view, I would want the same standard in general. And we may have very different opinions on that, but that was the other concern from last time, not having different rules for different categories of people.
Yeah, I think the I think the one possible difference here is the geographic proximity of 75 miles for a person who brings their child to the APRN and the nurse practitioner says, you need to go see my collaborating physician. I'm referring you to them. 75 miles is about as far as you really kind of want that person to travel and still still have it accessible, right? You can't say, oh, you know, go travel however many miles. The person can take off work. They can't do all these things. A prisoner is a little different. If you say, hey, you know what, you need to go see a physician, the state puts them in a car and they drive them there. The mileage is not as big of a barrier. They're not taking off work. They have transportation. Cost is not a barrier. And so they have different logistics of being able to go see a practitioner further away than a working mom that's trying to take off work or take a child out of school.
And I would just like to echo that I don't want there to be any sense that our request is an effort to somehow lower the level of standards or in any way the level of quality of care. Frankly, it's just the opposite. I am greatly concerned about our capacity to deliver timely and responsible care, and that's why we're coming forward, because of the unique challenges that we experience in correctional health care in recruiting that have only been exacerbated in recent years within the healthcare setting. These are unique times, and while we are going to be creative and thoughtful and innovative in how we recruit, these are simply unique and challenging times to recruit in healthcare, and especially in correctional healthcare. So I appreciated hearing all of you express your sincere thoughtfulness about this population, and that's why I moved from St. Petersburg, Florida to Columbia, Missouri, because this is a population that means a lot to me. I started my first 8 years of my career with the Indiana Department of Correction, so it's a population that I hold dear to my heart, and this request is only to improve our capacity to deliver care.
You know, Dr. Matthews, as a board member, I look at it a little differently. I look at it, this is not a quality issue, it's an access issue. And I think that lack of access actually is the problem and does decrease the quality of care. As far as I'm aware, you know, I think what happens is when you're in an academic center, your perception of what a collaborative practice is different than what my perception is being in private practice, because I see it every day. And there's no guarantee that a collaborative practice guarantees quality care. I could tell you that the APRNs that see the patients very rarely have any quality feedback from their collaborative practice physicians, you know. And that's one of the things I think as a board we need to look at is what kind of quality feedback is being performed by these collaborative practice agreements, you know. And I'm not really guaranteed that a 75-mile restriction improves the quality in any way. But I can tell you that lack of access, when you have a medical problem, certainly decreases the quality and the outcome.
I do think you and I share some similar concerns about our current statute and thinking about best ways to provide care. My experience in collaborative practice has only been within the St. Louis County Department of Public Health clinics and Affinia Healthcare. And
And
in the state of,
I will just
state of
say that
Illinois.
I will just say that I do bring some experience and probably some bias to the conversation. And I am oftentimes concerned about the collaboration or lack thereof between the Department of Corrections and the Department of Health in the manner that when we talk about healthcare, we always look, when we talk about healthcare for inmates, we always look to loosen or rearrange the healthcare arrangements and not the correctional facility arrangements. So I say that to say in the scenario that Georgian gave us in terms of mileage not being as much of an issue because the Department of Corrections will put them in a vehicle and take them. I will submit to you that if the Department of Corrections can't take them 75 miles because of supervision of officers and time off and things like that, then I stand before you to say you'll be back before us saying 200 miles is not enough, because you still have the same law enforcement piece that has to chaperone them to that 200-mile visit versus that 75-mile visit. So some of my own personal pushback is I hear the ask of us as healthcare to say, hey, let's help get these people access. But what I don't hear from law enforcement is how can we work with healthcare? It's always healthcare has to work within the rules of law enforcement. Law enforcement doesn't really have to bend as much to try to help these inmates get care. And I have to admit that that is some of the bias and some of the perspective that I bring before you. Dr. Lovelace, just your comment in and of itself, just in terms of collaborating with other providers means they have to have access. Well, if we're talking about access to the inmates and it takes these two entities to collaborate, that should not be a problem. If we can bend, they should be able to bend. And we're talking about access of professionals, which is likely a security clearance or whatever the processes may be. So it's not necessarily an attack, but just understand in respect for the profession, if we're asking professionals to be a little bit lenient about a subset population, then I think everybody involved has a responsibility to be a little bit lenient and not all of the leniency on one side and not the other.
Comments?
Yeah, I appreciate that.
All right, group, what would you like to do?
Are we able to vote in open session then?
Our vote needs to be an open. The only thing, if we have any questions for legal, we would want to go into a closed session for specific legal questions. If we don't have questions for legal, then we vote in open session. In order to do so, obviously, we need a motion of one way or another.
I would make a motion to increase the mileage to 200 miles for correctional facility APRNs, however that should be worded.
I just have a procedural question. Since we have to do that jointly with the Board of Nursing, procedurally, is it appropriate for us to put this forward as a motion today just with our board?
Legal?
I think we can go ahead and make the motion and then we can talk about it with the Board of Nursing next week during our meeting and see if they agree, and then can work out maybe like a joint motion next week.
Dr.
Yeah.
Hello,
Dorena?
this is Sheila Solon, the division director. Hello, everybody. I've been listening in. I believe the Board of Nursing last week had gone ahead and removed the entire 75-mile barrier. I believe you guys could go ahead and vote on the 200-mile if you wanted to have that mileage put in place, and then the Board of Nursing on their own would go ahead and vote on the same motion that you were to pass. I think that's probably the way it should work. I guess I'm trying to say you guys don't have to be in the room together voting on it. You could do it separately as board action separately.
And then if we have any discussions, with next week would be our opportunity to have those discussions or make sure that we get verbiage correct.
Dr. Durena?
I just want to clarify that the provider status that we're talking about are nurse practitioners. This does not include PAs. Am I correct?
We have 2 PAs, but we tend to attract nurse practitioners far more often than PAs. Our PAs have been long-standing members.
Do your nurse practitioners have other job opportunities along with correction? Are they full-time correctional nurse practitioners, general medicine, or are you allowing them to do anything else?
They're full-time. Most of them don't have a side job.
Thank you.
I would modify my motion to extend the waiver to 200 miles for APRNs and PAs in the correctional system.
Dr. Carter, you had a comment?
I do. Thank you. I appreciate very much, really all of the comments, particularly those of Dr. Taormina, who said that with regard to collaborative practice, we can really look at this as an opportunity to reimagine what collaboration would look like, and the fact that a simple arbitrary number of miles really may not be an effective indicator to ensure quality. I am hopeful, though, that as I think Mr. Runyon said, there are things that can be done to mitigate our risk as far as ensuring safety for this community. So if we're going to go ahead and vote, is it feasible to ask for a plan from Centurion about how that risk would be mitigated?
Is that a question for me or for the board? I wasn't sure.
It's for Centurion.
Yes, it is.
I think, Dr. Lovelace, we can certainly, we're open to reasonable expectations. We're pursuing the highest levels of standards, including CCHC standards of compliance. So, I am not sure what you'd be looking for, but certainly, we would be open to having a dialogue around that, or providing something, however you would like that formatted.
Agreements include an initial term of supervision, frequency of chart reviews. There are a number of procedures that could be put in place to ensure quality. So I'm asking you if you have any offerings to the board before we vote as to what you'd be willing to put in place to satisfy those of us with concerns that making a change such as this would result in a less standard for this community.
Dr. Lovelace, I'm going to defer to you because this would be your area of expertise, and these would be standards that you'd be overseeing and applying. Do you have any specific thoughts there?
So, and what time frame would you like to see these? That I guess would be a starting place for me.
Well, frankly, it would be my hope that before the board made a decision that there would be some safeguards in place. But ultimately, that's for the board to decide.
I did have a very specific question that builds on that, and that is part of the statute about posting, that this is specifically advanced practice registered nurse, and that informing patients that they have the right to see the collaborating physician. And I don't know how that gets handled in corrections. So I think one metric I'd be interested in is how often people, whether those things are posted, how often people make requests to see a physician, and that it's, does that happen or not happen?
Those the signage is usually posted in medical, and there's an occasional request. It's not frequent in my experience that people request to see the collaborating physician.
Mr. Chairman, I withdraw my motion. There's no second.
We have another motion. Do we need to consult with legal?
Jimmy, how many board members we have on the call?
Six.
We do have quorum. I mean, our options are we can vote favorably, we can vote negatively, we can vote to table.
Yeah, if you guys would like to table this discussion until after we meet with nursing to discuss these things with them as well.
And I would like to say again, if there's any specific requests that you would like us to agree to in advance of a vote that would make you feel more comfortable, you know, I would love to hear them. If there's a specific standard that you're looking for or would like to hear.
So here's one thought. You know, anytime you kind of venture into the unknown, you know, it's going to cause questions, right? And, you know, obviously the one thing we do know is the access issue will be limited until either the healthcare practitioner availability resolves itself throughout the nation, or you all, you know, loosen the standard. Otherwise, we have APRNs that can see these folks, but simply can't act in that capacity, and they can only be you know, see them in a registered nurse. And so the care, I do believe, is going to the access is going to decline, you know, clearly. So maybe, and I get the idea that you have to jointly promulgate a rule with the nurses. And so once you change this to 200 miles and you say, oh, you know what, that didn't work, and you can't get the nursing board to go along with you, then you feel somewhat trapped. So what if you agree to do 200 miles for a period of 6 months, and then that requires an automatic review, and we can discuss, look, it improved our access, care is better. We can show you what are in our collaborative agreements to ensure for quality. And if you don't like what, you know, what Centurion has done, then you can either modify it or let it sunset, and it would then go back to 75 miles. So you're not trapped at that point of not being able to change it again. And it kind of gives us something as a buffer for now. And it gives you all some certainty that you all get to kind of review this again and get to do something about it if you don't like what's happening.
And if I could just affirm that proposal, we have nurse practitioners who have been, I've been trained to retain, who have been acting in the capacity of an RN in hopes that we might be able to get some action on this, who I believe we're not going to be able to retain much longer, which is going to continue to reduce access to care and just deepen the crisis, frankly, that we're facing. And I've even extended offers to nurse practitioners on the hope that we were going to possibly get some action, just because we recognize the depth of the challenge that we're facing, and I didn't want to lose any candidates and providers that could come onto our team. So any relief at this point that could allow us to start improving access to care would be greatly appreciated.
So I find that an intriguing suggestion. This is just me thinking out loud. The kinds of things I would be interested in 6 months were recruitment and retention data. And then around quality, it's not just compliance with the agreement, but if there are clinical quality metrics that you track or your national organization tracks, I think that would be helpful. And I guess I would also want to hear that if extending the mileage limitations didn't solve your problem, it turned out to be a deeper recruitment problem, I would be interested in knowing, to Dr. James Halbert's idea, what local collaborations you have started investigating or putting in place as alternative or complementary ways to meet the need. And I appreciate your patience with all of our questions. So I'm gonna step forward and kind of try to bungle through a motion that would be extending to 200 miles for this 6-month trial period with a follow-up quality report back to us as we're coming to the end of that time.
And just to clarify, Dr. Matthews, this is for APRNs and PAs within the Department
Yes.
of Corrections? Okay.
Yeah.
Sunset at 6 months, or if it doesn't continue, what kind of verbiage do you want on that at 6 months?
I still like my language of 6-month trial period with the various aspects of a quality report coming back for reconsideration to extend or retrench at that time.
I think we should really clarify what happens at 6 months if that doesn't happen.
So I think we would be making a decision based on the report that's brought back to us. I can imagine that the 200 miles perhaps doesn't solve all the recruitment problems. And then we may not want to back out down on the 200 miles, but we would really be having a frank conversation about what else is corrections doing to improve access, since that is something we all care about. It might be the case that for whatever reason, we thought we would go back to the 75. I guess my futurism lens doesn't really see that, but still, because we don't want to get into unintended negative consequences, I think having the ability to relook at this with some expectations about reporting back, I find helpful. I'm partly trying to channel some of what Dr. Carter was saying, although this may not address his concerns, but that's what I'm trying to put forward.
So what would you want to happen specifically at 6 months if that doesn't? What do you want to happen at 6 months if this doesn't happen? To continue, or to turn to go back to 75 miles? Unless we extend
You
it.
may
What
not like
happens
the
passively?
language or the proposal, but the purpose of a trial period would be to see how it worked. So I am not putting in this proposal anything that goes beyond 6 months. The board would have to reconsider at that time.
I think Dr. Matthews, in line with what you're saying, and yes, this moves the target, but I think the numbers or the evaluation method should be brought back to us at 4 months.
Okay.
So we're ready to make an active decision at 6 months. You know what I mean? So it gives us
yes.
months 5 and 6 to sort of, it gives us time, I should say, to look at the information presented so that at 6 months we can then make an informed decision to either continue or abort or whatever is going to happen at the actual 6 month mark. So looking at what has happened at least in the 4 months to give us some something to take action on at the 6 month mark.
What she said.
Centurion, do you think is that doable on your part?
I'm sorry, that's a question for me?
Yes.
Yeah, yes. So what I'm hearing you say is in 4 months that we would come back to you with a report addressing, providing data around our recruitment experience, retention experience, as well as any metrics around continuous quality improvement and delivery of care, access to care, as well as what local collaborations have possibly been explored and what our experience is around these, around the most challenging sites that we're experiencing this, what the potential local collaborations could be. Is that a good summary?
Yes.
And to answer your
And
question, yes, we'd be happy to do that.
yes, and it does address the concerns that I brought forward, that this is a way to kind of move our concept of what collaborative practice is forward. And if we're going to change the requirements, know that we're doing it in a way that fosters improvement for the patients accessing care. So I will second Dr. Matthews' motion if it hasn't been seconded already.
Dr. Durrani, you have a comment?
I have a question. Kent, how many facilities do you have in Missouri?
We currently have 21.
And so is that, do you know how many facilities there are in the state of Missouri, or prisons?
21. So we're at all the prisons, but we're going to be also entering 2 additional ones, which will be Transition Center of St. Louis and Transition Center of Kansas City. So those will be additional ones that we'll be bringing online next month.
But as far as the state goes, do you know how many entities there are prison-wise?
I mean, Dr. Lovelace, it is that 21 currently, correct?
Correct.
All right, thank you.
Any other questions? We do have a motion and a second. Is there any further discussion? Seeing none. Jimmy?
All in favor? Any opposed? Okay, 4-2. Motion passes.
We appreciate your time. Thank you.
Thank you for appearing tonight. We appreciate it, and for your guests as well to help answer some of these concerns and questions. We appreciate it very much.
Yeah, you bet. Thanks
Of
for having
course.
us on.
Thank you for the opportunity to have a dialogue about this.
Yeah, you
Thank you.
bet.
Thank you for your time.
Thank you.
Need a motion to go into closed?
Does anybody else have anything for open? We would need a motion to go closed.
So moved.
Second.
The motion to go into closed session pursuant to sections 610.021, subsections 1, 3, 5, 7, 13, and 14, section 324.001.8 and .9, and section 334.001 RSMO.
Dr. Glazer,
Aye.
Dr. Taramina. Is Dr. Taramina?
We lost him.
Dr. Carter,
Aye.
Dr. Drenna,
Aye.
Dr. James Halbert,
Aye.
Dr. Matthews,
Aye.
and Dr. Taramina. Did we get you back? No, we did not. Okay, we are enclosed.